Good morning, good afternoon, and good evening, everyone, from wherever you're joining us. And welcome to today's webinar titled Navigating the Clinical Outcomes Maze, an overview of clinical outcomes assessments and why training matters, featuring experts who will delve into the dynamic landscape of COAs, examining their historical use and significance, current uses and best practices, and make a case for greater standardization in their implementation. I'd like to thank the sponsor of today's event, ICON, for making it all possible. I want to take this moment to introduce our speakers for today's session. We have Kelly Lipman, Principal in Patient-Centered Outcomes with ICON. Kelly acts as the Scientific Project Director for Rater Training. Next up, we have Heather Dickerson, a Senior Outcomes Researcher within ICON's Patient-Centered Outcomes team. She acts as a Scientific Research Lead for Rater Training. And our third and final speaker is Dr. Ryan Murphy, an Outcomes Researcher in the Patient-Centered Outcomes team within the ICON Insights Evidence and Value Group. And now, without any further delay, I'm very pleased to welcome our first speaker, Heather, to join me. Hi, Heather. Take it away.
Thank you so much, Sydney. Well, it is a pleasure to be here with you all today. As Sydney mentioned, my name is Heather Dickerson. I'm a Senior Outcomes Researcher here with ICON. So let's take a quick look at what we'll be discussing today. We'll start out asking ourselves the question, how did we get here? And we'll try to answer that by taking a look at the origins of COA within the health economics landscape. After that, I'll turn it over to my colleague Kelly, who will ask the question, are we there yet? And we'll take a look at COA in the modern health economics landscape. Before finally we move over to my colleague Ryan to ask the question, where do we go from here? And we'll take a look at the future of COA in health economics before finishing up with a quick Q&A session. So let's start with the question, how did we get here? So first things first, let's take a look at a few definitions. Before we begin, it's important to get these out of the way just to make sure we all start from the same base of understanding. So first, what exactly is a clinical outcome assessment? Well, the FDA defines a clinical outcome assessment as an outcome that describes or reflects how a patient feels, functions, or survives. Assessment of clinical outcomes can be made through a report by a clinician. That's called a clinician-reported outcome. It can be directly reported by a patient in what would be called a patient-reported outcome. It can be reported by a non-clinician observer through an observer-reported outcome. Or finally, it can be a report through a performance-based assessment, as you would see in a performance outcome assessment. You'll hear more about these terms and these concepts as we go throughout the presentation today. As mentioned earlier, the FDA defines a clinical outcome assessment as a measure that describes or reflects how a patient feels, functions, or survives. So while the term itself has emerged relatively recently, the concepts at the core of clinical outcome assessments stretch pretty much as far back as medicine itself. As we know, Hippocrates is often referred to as the father of modern medicine. And Hippocrates followed a holistic paradigm of medicine that was centered on a healthy mind and a healthy body. This Hippocratic approach included assessment of nutrition and lifestyle factors in his evaluation and treatment of illness. So this paradigm and the legacy of Hippocrates, of course, carries on even today, reflected probably most clearly in the details of the Hippocratic Oath that is still given by healthcare providers even through today. The oath stresses the importance of these core concepts of clinical outcome assessment through reminding providers, I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to adequately care for the sick. So with that framework in mind, let's take a quick look at a little bit of a path, if you will, the path that we followed to get where we are today, to a standardization of clinical outcome assessment. So, of course, as you can imagine, it would be a long road between the introduction of this Hippocratic ideal of holistic medicine and the recognition of clinical outcome assessment as a dedicated field of study. The first recorded clinical trial of sorts wouldn't take place until the 18th century in 1747. This is when Dr. James Lind used observation of sailor health combined with an experimental design that evaluated differing dietary practices to find a viable treatment for scurvy. So Dr. Lind based his observations on several different outcomes that might be familiar to us even today. So he looked at weakness of the knees, think 6-minute walk test or measures of lower body strength. He looked at overall health status, such as we might collect with a health-related quality of life assessment. And finally, he looked into dietary choices, such as we might receive with a patient-reported diary. Now, looking forward from there to the 20th century, we're going to jump to 1966, when Dr. Donabedian published his Evaluating the Quality of Medical Care, in which he described the structure process outcome model of healthcare evaluation. Dr. Donabedian concluded that one can only understand the effectiveness and quality of care provided by considering and including the evaluation of outcomes of that intervention. So he further noted the importance of choosing the correct outcome and that having different perspectives, such as those you would get from a patient, a clinician, or a family member, and then considering all of those contexts of those outcomes would be one of the best ways to avoid several of the pitfalls that we might encounter in the traditional health outcome measurement community. So this helps set the stage for outcomes research as we know it today. And of course, outcomes research would then go on to become a codified field of study in the 1970s. Since this time, we have seen several changes. We've seen the emergence of dedicated organizations such as ISPOR and the FDA Division of Clinical Outcome Assessment, just further codifying this real dedicated area of study that we now all look into. So we'll take another jump forward into the 20th century. Here in the 21st century, we've seen a massive push for standardization within outcomes research and then also within clinical outcome assessment itself, as this type of data collection has risen more in its presence and in its importance within the clinical research and the health economics landscape both. These standard and best practices can best be demonstrated now by looking into the introduction of ISPOR's Emerging Good Practices for Outcomes Research Task Force, as well as the FDA's Patient-Focused Drug Development Series, both of which aim to facilitate the advancement and the use of systematic approaches to collect and then to use robust and meaningful patient-centered data. And then that brings us to today, where, of course, the work for greater standardization continues on. We continue to recognize the growing need for training. And of course, we continue to further refine our approach to incorporating clinical outcome assessments into the endpoints for regulatory decision making as well as patient best care. Whoop, skip too far ahead of one. So to get another view on how the COA landscape has evolved over time in response to our growing body of knowledge, and as we shift a greater focus onto the patient experience, so let's take a look at the development of the 36-item short form survey, or the SF36, and then later at the 12-item SF12. So we'll start in the pre-1990s. So prior to the development of the SF36, the comprehensive COAs that we used for assessing the key general health domains like physical and mental health, social functioning, etc., they were pretty lengthy. Some of them could be up over 100 items in length, and commonly it would take the respondents more than 30 minutes to complete. Some of these assessments that we started out with included the McMaster Health Index questionnaire and the sickness impact profile, which of course, if you're familiar with them, you know, are quite lengthy. So in response to feedback that, of course, was received that respondents were feeling the burden of this completion, all of these lengthy instruments really did take a good deal of time during the healthcare setting. And so developers decided to approach the development of additional measures. This first push that we saw, however, looked more into single item measures, which of course didn't provide as much data about the patient's symptom and the impact of their care and their experience. So we were still missing some of those key endpoints, even as we were seeking to resolve the issue of the time burden. So of course, we continue learning on. This brings us to the early 1990s, where as part of the medical outcomes study, the SF36 was developed. The survey was developed to elicit the comprehensive health-related quality of life data that we saw from those earlier, more lengthy surveys, but to do so without the same burden that we would experience in the larger surveys. So the SF36 was developed and then further refined over time after that initial release in the 1990s. So jumping forward from there even a little bit further yet, in the 1990s, we started out with a past month recall period, which was updated in the version 2, 1998, to a wording of past 4 weeks to make it a little bit more understandable and easily recognizable, a push towards standardization, if you will. Additionally, some instructional text and some item text was revised in this version 2, again, to make the instrument a little easier for the participants and the patients to read and to understand to help improve the quality of the data that we were collecting. But of course, as you know, we can always improve even further. So, to further reduce the respondent burden, the SF-12 was developed. It was modified from the SF-36 with a goal of providing a solution for investigators and providers who found it necessary to restrict the survey time burden while still capturing the key information with the precision that's necessary for group comparisons. So, of course, this was accomplished by the SF-12. Looking into it a little further, a study assessing the physical component score as well as the mental component score of the SF-12 as compared to the SF-36 across 3 treatment groups found that the component scores for the 2 instruments were virtually identical. So now we have 2 excellent and well-validated choices for measuring these quality of life endpoints, and these happen to present less than half of the time burden for patients than we started with just 3 decades ago. So herein you can see a snapshot of where we are now and how we got here.
And I am happy to bring on Kelly to join me now. Oh, here we go, Kelly. Now you're unmuted.
Okay, sorry about that. Hi,
Take it away.
everyone. We're going to talk about where we are right now. And did the development of the SF-12 solve all of our problems, or do we still have a little bit more work to do? So in this section, we're going to go over kind of the back to basics, a couple of case studies, the impact of COA on patient-centered care, and also some keys to effective COA data collection. So going back to basics here, I really wanted to break this down, looking at the difference between signs and symptoms, and then I'll even talk about impacts as well. These are the things that are measured by COAs. So a sign is something that's observable or measurable. Some examples include, your biomarkers, weight change, respiratory rate, heart rate, blood pressure, things like this. Where symptoms, there are things that are felt by patients that cannot be easily observed on their own, like pain. If somebody says that they're in pain, you can't observe if it's a stabbing pain or a stinging pain or a burning pain, or even the severity of that pain. There might be cues that you can observe, like a grimace or an increased heart rate, sweating, things like this, but you're not able to actually determine any of the characteristics of these symptoms. So some examples, dyspnea, the shortness of breath. Um, that's something that somebody feels. You can see that somebody maybe is working a little harder to breathe, but again, that feeling of being short of breath is not something that you can actually observe, or heart palpitations, or like I said, pain. And then more distally, we could talk about impacts. So you have these changes in signs or changes in symptoms, but how do they impact emotional health? Somebody's moods over a period of time, or their ability to go out socially, things like this. So these are really what we're measuring when we use COAs. Um, so we talked a little earlier about the different types of COAs, but just to break it down a little bit more. So patient-reported outcomes, these are ideal for assessing symptoms and impacts, or those things that can't be easily observed. And they're also ideal for assessing health-related quality of life from a respondent's perspective. A ClinRO, or clinician-reported outcome, that's ideal for assessing signs, and really it obtains the clinician's perspective. Um, Again, these are usually observable things, but they tend to be a combination of either biomarkers or just signs that the clinician can observe. OBSROs, or observer reported outcomes, they're ideal for assessing signs from a caregiver or other observer's perspective. And performance outcomes, these are ideal for obtaining a quantified assessment of a patient without any subjective influence. Um, One that's very commonly used is the 6-minute walk test. This would be a performance outcome. So as far as best practices in COA standardization, just a very high level approach to how we develop new COAs. Um, we usually start with doing a landscape assessment. This is, a targeted literature review, just really doing research on what has already been published, doing a gap analysis to see where there are gaps in the research, doing expert interviews with key opinion leaders, and then drafting a conceptual model. Um, Another thing that is really important, that we're looking at measuring what actually matters to patients, and to do that we do qualitative research such as concept elicitation interviews or focus groups, We'll revise the conceptual model based on the results of the interviews or focus groups. And then we'll develop a conceptual framework for a new COA. And then we'll draft the actual COA instrument and again bring it back to the experts for their review and input on the draft instrument. Once we have a draft instrument that we feel really meets the needs from the gap analysis, from what we've uncovered in the qualitative interviewing process, and it really fits into the conceptual model, we'll take that draft instrument out to do cognitive interviews to find out, is this instrument being interpreted and understood the way that we're intending for it to be interpreted or understood? Are the questions challenging, too challenging, not challenging enough, too vague? And then we'll go through, it's an iterative process, and we'll do many revisions on this draft instrument and bring it back out in rounds of interviews until we have a consensus with all of the participants in the study that yes, this draft version is in fact going to be the best version of that instrument. Once we've kind of finalized, and we've from a conceptual point in the content validation of the instrument, we would then go into psychometric validation. This is where you have a very large sample testing the instrument to assess all of the psychometric properties of the instrument, and then we can say the instrument is finalized. So I wanted to speak to a couple of case studies. Now that we've got some valid COAs, what could possibly go wrong? One thing that I thought was really interesting, I came across this study that was conducted with 173 fourth-year medical students who were all asked to evaluate 6 standardized patients. And these patients, were all very similar in terms of what their characteristics of the condition were. And the medical students, had been trained on how to do history taking, physical examination. They'd been trained in interpersonal skills like soft skills and communication skills, counseling skills, and also just general etiquette for physical exams. And it was really interesting that the results of these exams across the 173 students who had performed them was that the severity reported for each of these 6 standardized patients was kind of all over the place. There was no general trend in severity for the patients, even though they were standardized to all actually be kind of at the same level of severity for their condition. So that kind of begs the question, was the training adequate? Was the assessment that they did standardized enough that we would get results that actually statistically make sense? Another case study, it was a recent study where migraine patients were asked to complete a daily headache diary just to log their headache symptoms. And it was discovered that these migraine patients, they were unclear about how to appropriately log in the diary a headache that, let's say, started late in the evening and persisted over into the next calendar day. They were unsure, do I log this as one headache for, let's say, Monday and a second headache on Tuesday because I still had the headache at 2, 3 o'clock in the morning? Or is this one headache that I'm logging only on Monday and then nothing on Tuesday, or only on Tuesday and nothing on Monday? And it was really interesting because, again, there was no training done for the sites for this trial. And so participants weren't trained on how they should appropriately log headaches that stretched over a calendar day. And so the results were, again, all over the place, where you had some patients that were double counting their headaches and logging that they had 2 separate headaches, even though it was really one headache event. And then you had other patients who just weren't logging the headache at all because they said, no, this is too difficult. I'm not sure what to do, so I'm just not going to log it. So again, this really greatly impacts your trial data. Another case study. This one is, it was based on a study where there was, we were trying to establish equivalence between an electronic interviewer administered pediatric questionnaire to an originally developed paper version of that questionnaire. This is something that happens in a lot of studies now where we've had this move to decentralized trials. And so paper and pen legacy questionnaires are no longer being used, but it's preferred to have questionnaires responded to on an electronic platform. So we try to establish evidence of equivalence between these two modalities. So in this study, to try to establish that evidence of equivalence, um, the researcher was playing the role of a pediatric patient and interviewing clinicians who would be in a trial setting, actually administering this administered questionnaire to the pediatric patients. And so during these mock administrations, the researcher realized that several of the clinicians were not actually reading the instructions verbatim for the instruments, either on the paper version or on the electronic version. They were just either swiping through those screens or in the paper version, flipping to the next page without actually reading the instructions. Um, and so as they're asking the pediatric patients the questions, they're supposed to be referencing, okay, I want you to look at the green response card to answer this question, or I want you to look at the blue response card to answer this question, so that the child is kind of grounded to what their answer choice pool is for each of the items. The clinicians weren't doing that. And so they would ask a question, for example, like, how did you sleep last night due to your asthma symptoms? And the pediatric patient would respond, oh, I don't know, somewhere in the middle. And the clinician would just select on their tablet 3 without confirming with the child, first of all, were they looking at the correct card? And, do you mean quite often or do you mean quite bothered? They weren't doing any of these checks to make sure they were in fact capturing the intended response from the pediatric patient. So again, in a trial setting, if this were to happen, you have clinicians not following the written instructions for the instrument, and really the trial data then is compromised because we don't know that this is accurate data reflecting what the patient experience is. Um, Another example that we have here is a clinical research site was taking part in a study that included several clinician-reported outcomes measures. One such measure considered a patient's spirometry performance as part of the scoring criteria, with very clear instructions that spirometry should be completed on the same day as the clinician-reported outcome measure for contemporaneous reporting of signs. Completion of spirometry had been delegated to another study team member at this site because the PI and sub PI were both away from the site briefly at that moment. So the study nurse who was delegated this task to complete was unfamiliar with the specific spirometry device and didn't feel comfortable completing this part of their task. So instead, they opted to average the patient's last two FEV 1% scores together from the last two visits, assuming that that number would be close enough to what they would actually perform there at the site that day. So the average FEV percent predicted was reported to the PI later for inclusion within the relevant clinician reported outcome measure and ended up being included in the live data set, even though it was never actually captured as it should have been. All right, so just again, bringing up why COAs are so important to patient-centric care. They really bring the voice to healthcare, clinical research, and regulatory decision making. You know, I mean, we have some quotes here from recent publications, but really the takeaway here is that the patient's voice deserves to be heard, but it also deserves to be heard as accurately as possible, right? We want to hear what the patient as an expert in their own health and their own experience is saying, and we want to do this in a standardized way so that we're not skewing any results in a study, right? So, as far as keys to effective COA data collection, I mean, you may recall that we discussed that some of the challenges associated with clinical outcome assessment a little earlier. But now we want to take a moment to consider the keys. Few key considerations to successfully and effectively incorporating outcomes measures into research and endpoints for regulatory decision making include the standardization, translation localization, equivalency testing, and training. So standardization, again, this is where, we're providing patient instructions exactly as they're prescribed in the assessment form or administration guidance, following all administration's rules, including like setup procedures and discontinuation rules. And if you think about, I gave the example of the 6-minute walk test, making sure that, everybody is administering this in the same way with a stopwatch, going for 6 minutes and measuring the same way. And adhering to scoring anchors is provided as part of that administration guidance. With regards to translation and localization, I want to ensure that assessments and interviews can be completed in a patient's primary language so that we're not running into challenges with patients having language barrier issues or misunderstandings or cultural misunderstandings, and ensuring that assessments do not lose relevance during translation or cultural variances, and that they're sensitive to all of the different cultures around the world. As far as equivalency testing and or cognitive interviewing and usability testing, again, this is where we look to provide evidence that there is equivalence across modalities of an instrument, be it from the legacy paper and pen modality to telephone administration or an interviewer administration, face to face or telephone, or an electronic administration. So we want to ensure again that the endpoints captured are consistent across all of the modalities there. And then training on not only rater training where if an instrument requires somebody to provide a rating, but also for co-administration training, how to administer the instrument in the same way across all sites and for all trial participants. This improves stability, it reduces variance between administrations, it reduces administration errors, and it's backed by recommendations of all the major regulatory oversight bodies, including the FDA, the EMA, and ISPOR has included this in their guidance as well.
And I'm happy to welcome Ryan on now to join me and to take it away.
All right, thank you very much. So, as Sydney said, I'm going to be discussing where we go from here and kind of the future of COA and the health economics landscape, taking a look at the impact of advances of technology on COA, the regulatory and industry changes that are coming up on the horizon, and generally being prepared for the future. So, we're going to be starting off in any discussion about the future. Really, the biggest topic in our industry and pretty much any industry is the impact of technological advancements and how it's going to impact us. It's particularly true when it comes to COAs and patient-centered data collection. So, over the past few years, data collection for COAs has been rapidly and drastically changing. Some good examples of this are with eCOA data collection. Through clinical trials, a lot of clinical sites are receiving study provision tablets where they can enter data from any cliniros that are being collected. Um, as Kelly was saying, we have seen transitions from paper administration to electronic administration. And even when this is done by clinicians, we need to actually test that this is being done appropriately and without actually impacting the quality of the data that's being collected. Going further, ePro diaries are available to patients so that they can record the symptoms that they're experiencing in real time outside of the clinical setting. So Kelly also gave an example of this with the uh, headache questionnaires and the difficulties that might arise if a headache extends from the previous day to the following day or the subsequent day when the information is actually being entered. Everyone is walking around with wonderful little cell phones in their pockets that can prompt them to respond to these questionnaires, and they need to actually understand how to do that appropriately. Uh, Taking a step away from the patient reported, we can also look at actigraphy data, which is from motion sensors to corroborate any patient reported activities and track signs that the patients themselves may not be consciously aware of. Things like their heart rate, their sleep patterns, even more old fashioned pedometers to see how many steps they're walking in any given day as a proxy for their overall activity. And also, finally, telehealth is a new, well, not entirely new, but it is more emerging over the past few years, largely because of the COVID-19 pandemic. It's really kind of prompting us to rethink the traditional model of the patient coming into this clinical site to interact with a healthcare professional well, we might need a little bit more flexibility going forward. We can't always assume that that is going to be the case. So, given that technology is evolving in ways that can have a clear relationship with COA data collection, we need to consider some specific ways that these advances are likely to impact health economics and the clinical research landscape. As mentioned with the COA pandemic, there's been a shift towards more decentralized trials and different modes of administering these COAs. Another possible example is with an instrument called the EASY. This is a dermatological measure where the clinician would be assessing how much of a patient's body part, whether it's the torso or right arm, left arm, legs, etc., might be impacted by atopic dermatitis and also assess the severity. It can be very different if a clinician is seeing someone in person versus if they are looking at photos that that patient are submitting of these different body parts or body regions for assessment. So there can be a lot of variability introduced by administering the COA in this different manner. Also, there's broader accessibility of COAs and a greater potential for diversity in trial populations. A lot of people are walking around with cell phones, and as previously mentioned, that can be a way of administering patient-reported outcomes. And so, if you're getting a broader diversity of patients involved, that can also increase the variability in how people are interpreting the questions that they're seeing and different ways that they might be interacting with the questionnaire. As Kelly indicated previously, a patient might double report a headache or not report a headache at all because it's too difficult to figure out what the COA is actually asking for. All of these are really highlighting that these are opportunities for more rater training, COA administration training to try and cut down on some of that variability and make sure that things are being administered in a reliable and replicable manner so that we can trust the data that is coming in. Taking a step back from the initial administration, there's also the ability to more rapidly identify where training mediation is needed. With any measure, typically you're looking for a normal distribution of responses where there's kind of a center point where you would expect the majority of patient responses to come in and fewer at the higher end or lower end of the scoring spectrum. And if data is being monitored as it's coming in electronically, you can look for individual patients who might be responding in ways that would not be expected, or possibly even entire sites where there might be issues coming up with how they are presenting this information or how they are collecting information. And when this is being monitored electronically, that can be caught a lot more quickly than if previously when a site might be submitting paper documents that then need to be manually entered. Given the speed with which all of this is changing, there's also regulatory and industry changes coming on the horizon that can impact how we are administering COAs or incorporating them into the studies in the first place. Some of the upcoming developments to keep an eye out for include 2 new guidances from the FDA's Patient-Focused Drug Development Guidance Document Series. Quite the mouthful in that title there. But ultimately, these are Guidance 3 on selecting and developing or modifying fit-for-purpose clinical outcomes assessments. We need to make sure that the COAs that are being given are actually fit for the purpose of the population that they are going to. And then also also Guidance 4, incorporating these clinical outcomes assessments into into endpoints for regulatory decision making. More and more, we are seeing that these COAs might be used as secondary or even co-primary endpoints along with biological measures to be used for justifying the efficacy of treatments or even making label claims. As the FDA is a government body, they are not always the fastest to respond, though they are very diligent in the work that they are doing. But there is also other sources of guidance to keep up with, such as the ISPOR task force making their recommendations for performance outcomes, structured expert elicitation for healthcare decision making, valuing quality of life for children and adolescents, and economic valuations or pediatric utilities, and just value-based healthcare implementations. There are special task force within ISPOR that are releasing guidance on these that needs to be essentially kept up with. And so all of this kind of ties together into how we're preparing for the future and where do we go from here. So there are a few steps that can be taken to make sure that you're keeping up with everything that's going on. First up, keeping up to date with these guidance releases as they are coming out, and also any technological advancements that may be occurring that might impact how we are administering COAs. And ultimately, we have to embrace this changing technology and guidance so that it should an event like a global pandemic, for instance, happen, and we need to pivot in how everything is being administered and conducted, we can more readily do that. Also, as each of these new methodologies are coming out, that can possibly increase variability. So we need to proactively seek out education and training that's in line with these industry changes so that we can push towards standardization and really maintain the reliability of the data that's being collected. And since all of this information and change is coming from a variety of sources, it's good to build relationships and networks with colleagues to foster the exchange of ideas and knowledge. It's all well and good to have someone who is keeping up to date with the guidance that's coming out, someone else who's keeping up to date with any technological advancements. But if there's no communication between these two people or these two groups, then we're really missing out on a key opportunity to make the studies as reliable as we possibly can. Ultimately, ICON does have ways of dealing with this. My colleagues and I in the patient-centered outcomes group are here to help with navigating through this COA maze. So we offer a variety of expert partnerships that are designed to help bring the patient voice to your study and the story that you are ultimately telling. So whether this is through instrument expertise, the three presenters here today are all within the PCO group, where we help with selection, design, development of new COA measures as necessary, which Kelly discussed earlier, the methodology behind that, the refinement of these endpoint selections, and preparing COA dossiers for regulatory submissions. Also, we can do some interviewing to make sure that these instruments are fit to purpose and correctly implemented within clinical trials, whether this is through cognitive interviewing, usability testing, and the analysis of the data for the equivalence between previously used paper versions or even paper backups if that is necessary for a clinical trial. And making sure that these instruments are comprehensive and fit to purpose, and providing rater training to follow along these same lines to reduce the variability in the COA and data collection. We can also provide strategic consulting to make sure that everything is in alignment with what the FDA or EMA is looking to see with their submissions, and also analyzing the COA data as it comes in. We can also help with observational studies for quality of life assessments. As I mentioned with the cognitive interview and usability testing studies, this can be very important to do as you're looking forward to make sure that everything is fit to purpose, equivalent between the paper and electronic, and also assessing the ease of completion of the instruments on any given electronic platform or device. You never know where issues might come up. There have been previous studies where looking at patients with Parkinson's-like symptoms, the eCOA vendor was providing tablets in order for the measures to be completed, but they had these in protective cases so that should a tablet be dropped, it's not going to be damaged. That included a cover, which, because of Parkinson's-like symptoms, the patients had a very difficult time opening and actually getting to the tablet. So something like that may not intuitively come up, but does come up when you are doing a usability testing study. And finally, also with content validation, making sure through concept elicitation questions that the instrument being used is actually appropriate and comprehensive enough for the population that you are running this study in. And finally, this topic has come up several times where we've been discussing the need for rater training. So rater training at ICON has been developed through partnership of internal ICON experts to provide some comprehensive but flexible solutions to meet client needs. And we do have some partnerships that assist in that. First up, obviously, we with the patient-centered outcome groups can manage all rater training projects, design and conduct study-specific rater training as will be most suited for your clinical trial. We also work closely with the MAPI Research Trust, who oversees the licensing of a lot of instruments, and sometimes that comes along with specific requests for the administration from the developers of these instruments. And we need to make sure that that is incorporated into the rater training and implemented in the clinical trials appropriately. There's also the Firecrest team, which is a portal for basically everything in conducting the clinical trial. All of the data is collected in one place, and there is a 24-hour-a-day help desk that is available should any sites run into any troubles with their devices and data upload or conducting the trial. We also have the data management service, so assessing the study information as it comes in, and also highlighting when there may need to be some remediation training if there's any issues from data coming in from either individuals or sites. And finally, creative and digital services can help to produce fit-for-purpose rater training materials, including custom videos, e-learnings, anything like that that may be needed for a clinical trial. Rater training can be offered for all types of COAs and tailored to meet the needs of the trial, the indication, the particular assessment type that is being used. So this can include expert consultation on scientific and methodological approaches to the rater training to make sure that we are receiving quality data. Customized fit-to-purpose rater training programs are designed individually for each project, whether this could include any variety of materials, whether it's training modules, fit-to-purpose training videos, interactive presentations that are done in person or online, and quizzes tailored to make sure that everyone is actually understanding the material as it is presented. And also the evaluation of rater eligibility to ensure that the raters that are providing these COAs are actually qualified to do so, both for that measure and that they have sufficient experience with the clinical population in question so that they can adequately administer the questionnaire and we can be assured of the quality of the data coming in. And ultimately, all of this can be tracked through certification of the raters during the study startup and any remediation of the raters should any issues arrive over the course of the life of the project. So all of that provides an audit trail that the regulatory agencies are likely to want to see. And yes, I believe that that is the end of my portion, so we can go ahead and get into the Q&A. Sydney?
Thank you for your fantastic presentations. I'm excited to start the Q&A session. So the first question is, if the questions haven't changed at all, is it really necessary to perform equivalence testing just for electronic completion?
Oh, I'll take this one. I love this question. So yes, a short answer here is yes, it actually is. If there has not already been evidence that the instrument has been migrated to an electronic platform, like if there's an e-booklet in existence, or if there's a publication that's already been migrated from paper to electronic, then no, you would not need to retest it. But yes, when you're changing modalities, the way that an instrument is presented is so different. For example, I mean, the most basic things here, a paper version of an instrument might have 5 questions on one sheet of paper. But when you see it on an electronic platform, you're seeing 1 question at a time. Are participants viewing 1 question at a time and understanding each question in the same way that they are when they see all 5 questions on one sheet of paper, and they can refer back to a previous question to think about how, influence their answer for the next question? Or even with instructional text. If instructional text takes up a couple of paragraphs on a sheet of paper, but in an electronic platform is, just a few sentences across maybe 3 or 4 screens, are these instructions being understood in the same way? Is somebody taking time to read it more thoroughly in the electronic version and they didn't in the paper? It's really important to kind of evaluate all of that to ensure that how a participant's responding is going to be the same way. What is their thought process and how they're choosing their response? Is that the same way between the two different modalities? We've actually had instances of trials where they've changed modalities over the course of a trial, The pandemic is a great example of that. Trials started with all in person clinic visits, and people were completing paper and pen instruments at their site visit. And then the pandemic hit, and suddenly we went to telemed appointments, and we went to electronic platforms or interviewer administered over the telephone for COAs. And so, again, we wanted to make sure that participants are, in fact, understanding instruments in the same way. I hope that answers it.
Thank you. Yeah, great answer. Let's jump to our second question. What is the value of training for PROs? Aren't instrument instructions enough?
I can take this one.
Okay.
All right, so that is a great question, and it's actually one that we do get pretty often. So, when it comes to training for patient reported outcome measures, I think one of the important things to consider is what's the goal of the training? What is it that we're trying to accomplish here? So, the training that would be offered for a patient reported outcome measure would generally be more directed towards the site. So, the goal isn't necessarily to learn how to complete the scale in and of itself, but also a refresher on the best practices when it comes to how do we collect patient reported outcome data, and more importantly, how do we collect that while ensuring that we answer all participant questions and that we are available to them without influencing their responses. Of course, as we know, when we are in the room with our patients, when we're in the room with our participants, if they have a question, we're the ones that they come to with that. And so it is good to have some prior training and some experience under your belt so that the first time you're thinking about these questions and you're really evaluating how do we complete this in a standardized manner and how do I provide this guidance while still ensuring that the patient's voice is the one being reflected here rather than my own influence. So that's where training can come in. It's really an opportunity to review best practices and to brush up on our strategies, which of course we all know very well, having dealt with patient reported outcome measures many times in the past, of course.
All right. Thank you so much. Great answer. Um, let's move on to this next question here. What is the benefit of extra standardization training if the person administering the assessment has decades of experience with administration?
I can take this one too.
Thanks, Heather.
All right. So, one of the funny things that we've seen when it comes to standardization and performance, particularly as it relates to clinical outcome trials or clinical studies where we really do have a little bit more of standardized data that we can pull from. One thing that we've seen time and time again is that often training is the best predictor of standardized performance. It's even been found in a paper that was published by Targum and his colleagues. Targum et al. Found that when it comes to training, it is the best predictor and can even overcome a lack of experience when it comes to the performance of a standardized assessment battery. But in the other direction, experience was not as good of a predictor as training. And in fact, a lack of training was often not overcome when it came to rising to that same level of standardization. The training simply didn't meet the same threshold that you would see. Apologies, I should say the experience didn't meet the same threshold as the training. So we still strongly recommend that anyone who's dealing with these assessments do seek out that standardized training. Experience is wonderful, but training will take you that next way.
Excellent. Thank you for that. Okay, we're almost at the top of the hour, but I think that we can squeeze in this one last question here. So, how much impact has COVID had on the push for telemedicine and remote assessment?
I can field this to begin with, and the answer is huge impact. Again, when the pandemic first started, and there was just so much question about what what did the future look like for all of us. A lot of trials did come to a brief pause, but they needed to persist, and obviously we had to have trials for vaccines for COVID. And so we had to do something where we could incorporate getting the patient voice into our research and the patient experience, but without compromising anybody's health further by having in person visits. So the pandemic absolutely made this huge push then for telemedicine and remote assessment. But I think from a patient perspective, patients have gotten very used to the convenience of being able to complete instruments at home at a time and a place that's comfortable and convenient for them. So I think there's been this push now for more decentralized trials just in general. where people can actually do more from the comfort of their home and have less of the burden of having to go on site to do all of these different assessments.
Very interesting. I think personally, as much as I love the virtual aspect of things, sometimes in person is nice too. Getting to interact with other people.
Totally get that.
But that's great that that is an option for those who maybe can't. So yeah, any last words from any of you regarding that question? I think Kelly did a great job answering, so.
Mhm.
All right. I just want to say thank you so much to the three of you for your professional insights and knowledge today. It was such a pleasure to work with you and have you join us today.
Thank you so much, Sydney, for having us.
Thank
Thank
you so
you.
much.
In closing, we hope you enjoyed this HealthEconomics.com webinar sponsored by ICON, and I hope you all enjoy the rest of your day.